For the next 40 minutes, I'll be talking about the pathogenesis of melanoma. So the key points are that the WHO 2018 melanoma classification, which is the new classification, is based on pathogenesis and integrates molecular data. There are 9 main routes to melanoma in this classification. The classification identifies precursor lesions, nevi, in which there are generally just one pathogenic mutation, and also an intermediate lesion termed melanocytoma. This is a useful term for an intermediate lesion with approximately 2 pathogenic mutations. And then melanoma can evolve from nevus precursor, dysplastic nevus precursor, melanocytoma, or also de novo without an identifiable precursor lesion, but requires multiple additional mutations. So why is understanding the pathogenesis of melanoma important? So there are many shades of grey on the way to metastatic melanoma in terms of histologic features, and this makes the diagnosis of melanoma difficult. Understanding the shades of grey increasingly relies on non-H&E methods. The shades of grey guide therapy, and also understanding pathogenesis is key to understanding targeted therapy. So why 9 pathways? Well, melanoma is not one but multiple diseases that can be separated based on their cell of origin, etiology, clinical appearance, clinical course, and response to treatment. And there are multiple distinct evolutionary pathways with associated genetic alterations, each with a different clinical setting and behaviour. Different melanoma subtypes have different driver genes, and this reflects the cell type of origin, the vulnerabilities of that cell type, and the risk factors that that particular cell type is exposed to. And during this talk, I'll be making use of this table, which comes from Melanoma Pathology, New Approaches in Classification, which is a nice summary of the WHO 2018 classification. And this breaks down melanoma into the 9 pathways, 1 through 9, and also stages in evolution from nevus through melanocytoma to melanoma itself, and lists the important molecular changes at each stage. So here are the main initiating driver mutations in melanoma. BRAF is important in low chronic sun damage melanomas, amongst other kinds of melanomas. NRAS is important in high chronic sun damage melanomas, but also in congenital nevi. NF1 is important in desmoplastic melanoma and high chronic sun damage melanomas. c-KIT is important in acral mucosal melanomas, but also high chronic sun damage melanomas. G-alpha-Q pathway genes are important in uveal melanoma and also blue nevus, and melanoma arising from blue nevus. And kinase fusions are important in Spitz tumours. I'll also be making use of this figure, which is the mitogen activated protein kinase pathway, and it starts with a receptor tyrosine kinase. This could be something like KIT, but also the receptor tyrosine kinases which are involved in Spitz tumours are localized here in the pathway. Activation of a receptor tyrosine kinase activates RAS, and downstream of RAS is BRAF, MEK, ERK, cyclin D1, CDK4 or 6, and then resulting in proliferation. Also downstream of RAS is PI3K, AKT, and leading to cell survival. Some important additions: P10 is inhibitory at this point in the pathway, and P16 is inhibitory on CDK4 or CDK6. P16, the name of the gene is CDKN2A. And also NF1 is inhibitory on RAS. at this point in the pathway. So here are a couple of examples of why particular driving mutations are operative only in certain cell types. So thinking about uveal melanoma for a moment, it's invariably driven by mutations in the GNAQ, GNA11 signaling pathway, but not BRAF or NRAS. And this likely reflects differences in the cell type from which the neoplasm arises and or the microenvironment that leads to different vulnerabilities of the cell type for transformation. So it's entirely possible that there are BRAF mutations in the uveal tract, but they don't provide a selective advantage in the uveal tract, so they don't give rise to melanomas. In a mouse model, expression of mutant GNAQ in the germline of melanocytes leads to uveal melanoma, but not in skin melanoma. Instead, it leads to loss of epidermal melanocytes. Second example comes from neurofibromatosis. Neurofibromatosis caused by mutations in NF1, which lead to Schwann cell tumours, including neurofibromas, and malignant tumours, including malignant peripheral nerve sheath tumours. Melanoma is very uncommon in neurofibromatosis, even though sporadic melanomas are commonly associated with NF1, which seems rather contradictory. But there are some examples of melanocytic proliferations in neurofibromatosis. It's just that they don't progress to melanoma. So one example of that is a leashed nodule. It's a limited conjunctival melanocytic proliferation equivalent to a nevus, but which doesn't progress to melanoma. So here's an example of a leashed nodule in a patient with neurofibromatosis, and here's a biopsy of a leashed nodule. And I think you can see that it's a very benign looking limited melanocytic proliferation. And here's another example from neurofibromatosis. Café au lait macules, and this patient with neurofibromatosis has multiple café au lait macules, and these are in fact very low-grade melanocytic neoplasms with loss of both alleles of the NF1 gene, but they don't progress to anything beyond a very, very slight increase in number of melanocytes at the dermo-epidermal junction for reasons that we don't fully understand. So turning to the subject of tumour suppressors, in humans there are multiple tumour suppressors, including cell cycle checkpoint, telomere length, and also immune surveillance. Melanomas therefore need multiple genetic alterations that overcome more than one tumour suppressor. And as a result, tumour progression to melanoma typically occurs in discrete steps, as the tumour suppressors required for full transformation are incrementally overcome. This can result in partially transformed neoplasms in which progression is temporarily or permanently halted, for example, a nevus or a melanocytoma. So starting with the 9 pathways, pathway 1, low cumulative sun damage melanoma or superficial spreading melanoma. And this is in towards the left of the table, and there are nevus precursors, multiple intermediate tumours or melanocytomas, and then finally melanoma, and we'll discuss all of these in turn. So a couple of slides about nevi. Nevi arise more commonly on sun-exposed sites and have a UV mutation signature. They're a clonal proliferation of melanocytes driven usually by BRAF V600E. A single pathogenic mutation is thought to be sufficient to initiate a nevus. The nevus retains tumour suppressor mechanisms, resulting in a stable state. Other nevus initiating mutations, for example NRAS, are usually mutually exclusive with BRAF. The risk of a nevus progressing to melanoma is very low, and it's been calculated at approximately 1 in 33,000 nevi per year. Progression requires additional mutations that override tumour suppressors, and these are typically things like inactivation of CDKN2A or mutation of a TERT promoter. Melanocytomas are intermediate melanocytic tumours that have an additional pathogenic alteration that results in a second round of clonal expansion. So that would be BRAF or NRAS or some other initiating driver plus an additional pathogenic alteration. Because of redundancy of tumour suppressor mechanisms, backup mechanisms become engaged when one senescence mechanism becomes corrupted. And melanocytomas have a higher risk of malignant transformation than the corresponding nevus stage, but remains to be quantified exactly what that is. Some melanocytomas can spread to sentinel lymph nodes, but spread beyond sentinel lymph nodes to systemic sites is very uncommon. Examples of those would be the atypical Spitz tumor and the pigmented epithelioid melanocytoma. So examples of the second mutations in melanocytomas. In deep penetrating melanocytoma, there's usually a beta-catenin pathway activation in addition to BRAF mutation. In BAP1 inactivated melanocytomas, there's BAP1 loss in addition to BRAF or other driver activation. In PARCA1A inactivated melanocytomas, which are a subset of pigmented epithelioid melanocytoma, there's PARCA1A loss in addition to the initiating driver mutation. And they're usually clinically stable but can progress to melanoma through further genetic alterations, for example, CDKN2A and TERT promoter mutations. So here's an example of a combined deep penetrating melanocytoma. So I think you can see this is the lesion we're looking at. There's a background nevus, and arising within that is a more heavily pigmented nodule. This is what it looks like on dermoscopy. And under the microscope, this lesion is biphasic. Here's the deep penetrating component, and here's the conventional melanocytic nevus component. Zooming in, here's the deep penetrating component again, and the conventional melanocytic component. The deep penetrating component has cells which are larger, have occasional mitoses, have sort of granular pigmented cytoplasm, and also scattered melanophages. And we can visualize the second hit in these tumors with a big beta-catenin immunostain. So here's the conventional melanocytic nevus, which is driven by just a single driver like BRAF. And here's the deep penetrating nevus, which in addition has got a beta-catenin mutation, which leads to accumulation of the protein in the cytoplasm and also in the nuclei of the tumor. Here's an example of a BAP1 inactivated melanocytoma, and again this is an example of a biphasic tumor. Here's the precursor conventional nevus, and here's the BAP1 inactivated melanocytoma, which has got a second hit in the BAP1 gene. And zooming in, this is the conventional nevus. And BAP1 immunostain shows retention of staining. So the BAP1 protein, when it's active, is localized in the nucleus. And zooming in on the BAP1 inactivated melanocytoma component, here are the large epithelioid cells, and the immunostain shows loss in those large cells, but of course it's retained in the admixed lymphocytes because BAP1 is present in most normal cells. And here's an example of a combined pigmented epithelioid melanocytoma. It's a wedge-shaped tumor with very heavily pigmented. This tumor is also biphasic. Here's the conventional nevus precursor. Zooming in on the epithelioid melanocytoma component, you see these large epithelioid cells, some with quite large nucleoli and admixed melanophages. And here's the PARCA1A immunostain, which shows loss in the lesional cells, but retained in other cell types. This is smooth muscle of erector pili, and these are actually melanophages. Dysplastic nevi are the last kind of melanocytoma that I'm going to talk about. And this is a more poorly understood area and more heterogeneous. But I'd like to show you some of the figures from a 2024 paper. The MAP kinase driver mutations are in these rows with the blue band here. Each column represents one lesion. So, for example, in this case, had a BRAF V600E driver mutation and nothing else. So in yellow is BRAF V600E, and it shows that the bulk of the dysplastic nevi sequenced had a BRAF V600E mutation and nothing else detected. There are lesser numbers of V600K in black, also NRAS, KRAS, HRAS, NF1, KIT, CBL, and MAP2K1 as their initiating drivers. So the BRAF V600E driven dysplastics were in younger people. They also had longer telomeres and higher levels of P16, indicating that they're relying on the P16 CDKN2A tumor suppressor. The others were in older patients, that's these ones over here, had additional identifiable mutations, so qualifying as melanocytomas, also had shorter telomeres and lower expression of P16, indicating that they were not being held in check very well by CDKN2A, but rather by shortening of the telomeres or replicative senescence. That creates a selection pressure for TERT promoter mutations, and you can see that in some of these dysplastic nevi, there were indeed TERT promoter mutations. Looking at the corresponding H&Es, there are also identifiable differences with the V600E associated dysplastics more nested, more bridging of junctional nest, and more fibrosis around the rete, i.e. the classic dysplastic nevus, while the non-V600E nevi were more lentiginous with single cells, less nests, and more sun damage. So in this early data, it looks like distinct senescence mechanisms restrain progression in V600E versus non-V600E driven dysplastic nevi. So finally, coming to melanomas in pathway 1, low cumulative sun damage, they're mostly BRAF V600E, minority NRAS driven. They often have a nevus precursor. They have a low degree of solar elastosis and a younger age of onset with a sharp drop-off after the age of 50. So this figure compares low chronic sun damage melanomas to high chronic sun damage melanomas. And looking at the lower panel, the low chronic sun damage melanomas have an earlier age of onset with a peak about 50 years old and then a sharp drop-off. They're located on the chest, back, proximal extremities. They're also associated with nevi. What this figure doesn't show is that benign nevi associated with BRAF V600E peak in the first decades of life, so much earlier on, and then dramatically decline, so that the peak in V600E associated melanomas is 2 to 3 decades after the peak in V600E associated nevi. It's tempting to conclude that melanocytes of the trunk and proximal extremities may be especially susceptible to transformation following a BRAF V600E mutation that occurs earlier in life, but not later in life for unknown reasons. High chronic sun damage melanomas, in contrast, shown in the top panel, their incidence continues to increase in later life as sun damage accumulates. They occur mostly on areas of the body with the highest sun damage, so head and neck, and they have NRAS, NF1, KIT, and non-V600E BRAF drivers. So here's an example of a low chronic sun-damaged melanoma. See, there's a low degree of solar elastosis. Here's a precursor nevus, and here's the melanoma itself. I wanted to briefly show you one of the most powerful ways of studying this kind of melanoma and this lineage of melanoma. So it's sequencing after microdissection. So in this example, the nevus component is microdissected out and sequenced separately to the melanoma component. And by comparing the mutations present in the nevus to the mutations present in the melanoma, it's possible to produce these evolutionary trees of melanoma evolution. So in green is the nevus, and in purple is the melanoma. You can see the nevus just has a BRAF V600E mutation, but the melanoma in addition has acquired CDKN2A homozygous deletion and a frameshift mutation in ARID1A, which are associated with transformation to malignancy. And this figure in the middle shows a sort of pictorial representation of some of those changes. So here's the nevus component, here's the invasive component, and here's an early invasive component. And this is a P16 immunostain. So you see that the nevus component has retained P16, i.e. it's still producing functioning P16, and it's relying on that as its tumor suppressor. But that's completely lost in the melanoma component. And zooming in, here's the nevus component. We see high expression of P16. Actually, in the early invasive melanoma component, there's reduction but not complete loss. And here's the invasive melanoma component with complete loss. And if you look at FISH for CDKN2A, the gene associated with P16, you see the red dots show 2 dots in these cells, so it's retained both CDKN2A genes in the nevus component. In the early invasive melanoma component, there's only one red dot in each cell, so it's lost one allele of CDKN2A. But in the invasive melanoma, both alleles of CDKN2A are lost, leading to the complete loss of the P16 on the immunostain. So moving on to pathway 2, high cumulative sun-damaged melanoma, and this is an example of a high cumulative sun-damaged melanoma or lentigo maligna melanoma occurring on the face with a large area of lentigo maligna and then a smaller area of invasive melanoma. And this is where this is represented on the figure. So high cumulative sun-damaged melanomas have marked solar elastosis due to sun damage, usually no nevus precursor. The precursor that can be seen is a melanoma in situ or an intermediate lesion. The genes associated with them, as I mentioned, are V600K, NRAS, KIT mutations, NF1 loss, also RAS-A2, the latter two are negative regulators of RAS. And here's an example of a precursor lesion. It's a melanoma in situ, lentigo maligna type, occurring on severely sun-damaged skin. And here's an example of a high cumulative sun-damaged melanoma or lentigo maligna melanoma. Here's a melanoma in situ component, and here's an invasive component. As you can see, very heavily sun-damaged skin. So that's it for pathway 2. Pathway 3 is desmoplastic melanoma. We already have seen this figure, but this you can see is very clinically distinct. They're not very pigmented. There's an area of sort of induration, which can be hard to diagnose clinically as well as histologically. This is where they feature on the table. So desmoplastic melanomas, it's a variant of high chronic sun-damaged melanoma usually. They have NF1 inactivating mutations, but also other mutations in the MAP kinase pathway. The pure subtype of desmoplastic melanoma, when it's more than 90% desmoplastic, infrequently metastasizes to lymph nodes and therefore has an improved survival. They do they can be locally aggressive via neurotropism. Pathway 4, Spitz melanoma. This is an example of a atypical Spitz tumor in the Spitz melanoma pathway occurring on a child. Here's where they feature in the table. So Spitz melanomas and Spitz pathway, the characteristic drivers are HRAS mutations, often accompanied by amplification of the HRAS locus. And then the remainder of the pathway is gene fusions of receptor tyrosine kinases, for example, ALK, ROS1, NTRK 1, 2, 3, RET, MET, and MERTK. So those are receptor tyrosine kinases, but also fusions of serine threonine kinases in the MAP kinase pathway, and examples of those would be BRAF, RAF1, and MAP3K8. They have a benign manifestation, the Spitz nevus, but also an intermediate manifestation, the Spitz melanocytoma, has previously been called atypical Spitz tumor. These can have homozygous deletions of CDKN2A, but without additional driver mutations such as TERT, they have an indolent behavior. Evolution to Spitz melanoma is accompanied by inactivation of CDKN2A, loss of P10, TP53, and also promoter mutations in TERT. They're distinct from melanoma with Spitzoid features, which we covered in the earlier lecture. And so melanoma with Spitzoid features conventional drivers such as BRAF and NRAS has a much worse prognosis, but can mimic Spitz melanoma histologically. So here's an example of a Spitz melanoma. This case has an ALK fusion, so it's definitely Spitz lineage, but also has multiple copy number gains and losses, including CDK4 amplification. Next pathway is acromelanoma, pathway 5. Here's an example of a acromelanoma. Here's where they feature on the table. There are two main categories in acromelanoma. There's the acrolentigenous melanoma subset, and these feature KIT mutations, non-BRAF V600E mutations, and kinase fusions. They have a low point mutation burden, as you'd expect from not being on a very sun-exposed site, but more copy number changes. The in situ component can be very broad, indolent, with a long time to progression. TERT copy number amplification actually can precede the MAP kinase mutation in these melanomas, and because of the very broad in situ component, it can blend into a surrounding field effect which shares copy number changes, including pathogenic amplifications with the adjacent melanoma in situ. And there's also a subset of acromelanomas have BRAF V600E, and those are similar to low chronic sun damage melanomas, and they may have a pre-existing nevus. So here's an example of an acromelanoma. Here's the broad in situ melanoma, which blends with the surrounding field. And this is a copy number plot produced by SNP array. And what this shows is there's some focused amplifications. In chromosome 5 here, you see there's a very striking focused amplification, and this corresponds to the TERT gene. So there's overexpression of TERT by amplification of the gene rather than TERT promoter mutation in this case. And also here there's amplification of CDK4 and MDM2, as well as many others. Pathway 6 is mucosal melanoma. Here's an example of a oral mucosal melanoma, which is visible on the mucosa of the lip. Here it is in the table. Mucosal melanomas are enriched for KIT, with spread 1 being an additional driver on the way to melanoma. GNAQ can feature. In genitourinary melanomas, additional mutations on the way to melanoma particularly feature SF3B1. That doesn't feature in sinonasal melanomas. There are more copy number changes and a lower point mutation as you need sun exposure for that. Pathway 7 is melanoma arising in a congenital nevus. So here's an example of a bathing trunk nevus in a child, and these nodules are actually proliferative nodules rather than melanoma arising in a giant congenital nevus. Here's where it features on the table. So giant congenital nevi are particularly driven by NRAS. Smaller congenital nevi arising after birth are associated with BRAF V600E, and this implies that NRAS is particularly good at driving proliferation in neural crest progenitor cells, but BRAF not so well in this cell type. The risk of melanoma developing in a congenital nevus is 2.5 to 8% in giant congenital nevi over 20 centimeters in size. The melanomas are mainly in childhood, with 70% before puberty. One particular challenge in congenital nevi is proliferative nodules, which have a benign behavior, and those typically have copy number gains and losses of entire chromosomes, whereas melanoma in congenital nevi just has copy number gains or losses in parts of chromosomes. Here's an example of a melanoma arising in a congenital nevus. Here's the background congenital nevus. Here you see the background congenital nevus and the melanoma. This is a small cell melanoma type. The cells are highly atypical and mitotically active. As I mentioned, the challenge is distinguishing these histologically from proliferative nodules, which are actually much more common. And here's an example of a proliferative nodule. Here's the background congenital nevus, but I think you can see there is maturation in this proliferative nodule, so they're more heavily pigmented cells superficially with loss of pigment in the deeper portions of this proliferative nodule. It's less mitotically active, and the cells are also cytologically more benign. Here's an example of the use of TERT mRNA in situ hybridization to distinguish melanoma arising in a congenital nevus from a proliferative nodule. So here's the melanoma. Cells are a bit more cytologically atypical with prominent nucleoli and more frequent mitoses. And here's the TERT RNA in situ hybridization showing high expression. And this high expression is because of TERT promoter hypermethylation leading to paradoxical overexpression of TERT mRNA. So this would not be picked up by TERT promoter sequencing because it's hypermethylation rather than point mutation. In contrast, here's a proliferative nodule arising in a congenital nevus. It's cytologically more benign and doesn't have TERT RNA overexpression by the TERT RNA in situ hybridization. So pathway 8 and 9 are melanoma arising in a blue nevus and uveal melanoma. Here's an example of a plaque type blue nevus, a large congenital plaque type blue nevus, in which several cellular blue nevus arose, and then ultimately a malignant blue nevus arose with fatal outcome, unfortunately. And here's an example of a uveal melanoma that's visible by fundoscopy and also on an exenteration specimen. And it's a melanoma, uveal melanoma growing as a mushroom-shaped tumour that pushes up and detaches the retina. here they are on the table. And melanoma arising in blue nevus and uveal melanoma are a different cell type. They're melanocytes without epidermal connection deposited in the dermis during neural crest migration. This likely explains the segmental distribution of nevus of Ito and Otar, which have identical driver mutations. So the driver mutations are G-alpha-Q pathway activating mutations, predominantly GNAQ and GNA11, but rarely mutations in the upstream receptor cis-LTR1 or the downstream effector phospholipase C beta 4, and those give rise to all the tumors in this pathway, which is why they're clustered together, including blue nevus and blue nevus-like melanoma and uveal nevus. Markers of progression in this pathway include BAP1, biallelic inactivation, and hotspot mutations in SF3B1, or mutations in EIF1AX, giving progression to melanoma. You can see copy number loss, which also results in chromosome 3, which results in loss of BAP1. And this figure, I think, is a little bit helpful. It shows the G-alpha-Q signaling pathway. Here's GNAQ or GNA11. Here's the other genes that are important in the pathway, cis-LTR2 and PLC beta 4. So you can see that mutations in cis-LTR2, GNAQ or GNA11 or PLC-B4 would all have a similar result. And the mutations in the GNAQ and GNA11 damage the ability of those proteins to break down GTP, leaving the protein in the active state, activating the pathway. So here's an example of a melanoma arising in a blue nevus with a GNAQ mutation. Here's the nevus, here's the blue nevus, and here's the melanoma arising in it. Zooming in, here's the blue nevus and the melanoma arising in it. Both of these have the GNAQ mutation. The nevus has retained BAP1. You can see these very small nuclei still have red immunostaining, but the melanoma has BAP1 loss, indicating which is associated with progression to melanoma. So final thoughts on the WHO 2018 classification. Genetic drivers and the level of chronic sun damage are given more weight. Nodular melanoma is not a genetically distinct entity, so it doesn't feature as an entity. And also, although it's a great framework, it's still evolving as we improve our knowledge of the molecular drivers. So one slide on inherited melanoma and the way it illuminates the pathogenesis of melanoma. It's quite common, 12% of melanoma patients. And here are some of the key genes that are mutated in inherited melanoma. CDKN2A, the dysplastic nevus syndrome, CDK4, cyclin D1, TERT promoter mutations, POT1. POT1 stands for protection of telomeres. This, like TERT promoter mutations, results in elongated telomeres. BAP1 we've looked at, but there's also inherited syndrome with BAP1 loss that results in melanoma, and P10 loss results in Cowden syndrome, in which melanoma features. And here's the MAP kinase pathway figure again, showing that where those genes show up. So CDKN2A, germline loss, the protein is P16, that's inhibitory on CDK4 and CDK6, which also feature in mutations in these also feature in inherited melanoma. Interestingly, the mutations result in inability to bind P16 and to be inhibited by P16. Other genes which are mutated in germline melanomas include P10. So recommended reading, the Melanoma Pathology, New Approaches and Classification paper which I mentioned, also a terrific review article from melanocytes to melanomas, and also this longer review article, Molecular Pathology of Melanoma and Integrated Taxonomy of Melanocytic Neoplasia. And these lectures, if you want to go back, are on my YouTube site, and this is the link. Thank you very much. Any questions?